let's get started with today. And I would like to welcome to the floor Professor James Chalmers from University of Dundee, who will be giving the plenary lecture, What Can We Learn from Looking Beyond CF? Welcome, James. Please remember, if you have any questions for James, you can put them in the Slido app and we can ask them after. Welcome, James.
Thank you so much, and thank you to the organisers for inviting me, although I'm a little bit disappointed after the poster awards. I thought I'd get some intro music. I've never had that at a conference. It would have been great. I am really excited to be talking to you. This is, I think, a really exciting development in the last few years, that there are new treatments coming for non-CF bronchiectasis, and there is a lot of conversations going on about how that may impact what we've just been hearing about in terms of trying to find treatments that can help people also with cystic fibrosis. So I'm going to talk about some of those developments in bronchiectasis, how that may intersect with cystic fibrosis, and then I'll talk later about what issues we might have to address if these treatments are to reach people with CF. These are my disclosures. I'm actually going to show you a number of studies that we've done with pharmaceutical companies, so important that you're aware of that. There are clearly major commonalities between cystic fibrosis and non-CF bronchiectasis. And as we get more and more data in bronchiectasis, I always say that we're about 20 years behind cystic fibrosis, and that may be being generous to the field of non-CF bronchiectasis. We find more and more commonalities. If we think about inflammation, these are both diseases that are characterized by chronic neutrophilic inflammation. If we look at studies, one on the left from the United States, looking at the relationship between neutrophil elastase levels and lung function, you can see almost the same data in a study we published in 2017 in bronchiectasis. Also in bronchiectasis, a strong relationship between the levels of neutrophilic inflammation and the risk of exacerbation, and that's catalyzed a lot of the development of the anti-inflammatory field in bronchiectasis, and I'll spend a bit of time talking about that. Bronchiectasis is also characterized by chronic inflammation, as is cystic fibrosis. And on the left is the data from the CF registry that everybody in this room will be very familiar with. The right is the data from the bronchiectasis registry in Europe, where Pseudomonas aeruginosa is also the most common pathogen. And interestingly, saw data at the ERS shown of the 2024 CF registry from the US, that Pseudomonas is still affecting a quarter of CF patients in the post-modulate era. So the issue of chronic inflammation has not gone away. The issue of chronic infection has not gone away, and is certainly a very active one in non-CF bronchiectasis. And then mucociliary clearance, or impaired mucociliary clearance, is clearly a major issue in both diseases. This is rheological data. On the left-hand side is from Marcus Moll's work, showing that rheological properties of sputum are improved by the administration of ETI, but not to the levels seen in induced sputum from healthy controls. And on the right is the heterogeneous but nevertheless grossly abnormal rheology seen in people with non-CF bronchiectasis. So we have the same treatable traits across both diseases as you would expect. In terms of inflammation, pre-modulator neutrophilic inflammation is higher in people with cystic fibrosis, an order of magnitude higher compared to NCFB. On the left-hand side here is neutrophil elastase activity in BAL. On the right-hand side is neutrophil extracellular trap levels from one of our studies, and an order of magnitude greater than healthy controls or the airway diseases like COPD or asthma. This has now changed with the advent of the modulators. This is one study, but there are a number of studies, including the one I referred to earlier from Marcus Moll's group that was published in the ERJ, that have looked at the levels of inflammation pre and post modulators. In this study, they looked at patients over 12 months, measurement of inflammation at baseline, measurement of inflammation at 3 months and 12 months, and compared to a control population of NCFB. It's a small study, it's 30 patients. But the overall message is that there's a marked reduction in inflammation after administration of ETI, and the levels drop to about what you see in people with NCFB. Importantly, the paper from Marcus, which I'm not going to show in the interest of time, shows that these levels are still substantially higher than controls. So inflammation gets better, but the problem hasn't gone away. Mucus rheology gets better, the problem doesn't go away. Microbiology improves, but the problem doesn't go away. And these features are starting to resemble more like non-cystic fibrosis bronchiectasis, which raises the question, could we be using some of the therapies in development for bronchiectasis for people with cystic fibrosis if the biology makes sense and if the treatable traits are still present? There's an important comparator here, which is primary ciliary dyskinesia, a genetic cause of bronchiectasis. These patients are heterogeneous. They're different to the non-CF bronchiectasis population. If you look at some of our recent clinical trials, they are 30 years younger. They have higher levels of baseline inflammation, a higher burden of disease, yet they're included in bronchiectasis trials. They're included in the large anti-inflammatory trials and in some of our current anti-infective trials. So if that's the case, why could cystic fibrosis not also be part of that treatable traits approach in a one bronchiectasis concept? This paper is just online at the European Respiratory Journal. It's from the German group again. And they've looked at rheological properties, inflammation, and microbiology compared between CF and primary ciliary dyskinesia, and then the CF population after ETI. And the message is clear and consistent with what I've just shown you, which is that PCD and CF patients have much higher levels of inflammation and abnormal rheological properties compared to controls, and that after ETI, the higher levels that are seen in CF return to approximately the levels seen in people with PCD. And at the ERS Congress, I showed some data from some of the anti-inflammatory trials showing that patients with PCD are benefiting. And so that is an additional argument that there may be the potential to look at these heterogeneous populations in single trials. So what are we actually doing currently in bronchiectasis, and what are these therapies that could potentially be bridged into cystic fibrosis? Well, a lot of the recent activity has been around anti-inflammatories. And I know anti-inflammatories have a checkered history in cystic fibrosis, most famously BIIL-284, which was a leukotriene B4 receptor antagonist, which blocks the recruitment of neutrophils into the airway, was tested in people with cystic fibrosis and actually worsened lung function and increased the risk of exacerbations in adults and children. And this, I think, has caused a degree of reasonable concern within the CF community about targeting the neutrophil. And it's been an area that hasn't seen as much activity in recent years. Similar results have been seen with other drugs that target recruitment of neutrophils, including the CXCR2 antagonists. I was involved in studies of those in COPD, where there was an increased risk of infection. So with anything that's anti-inflammatory, we need to be extremely cautious that we can get beneficial effects without increasing the risk of infection. And the big development in bronchiectasis in the last 10 years has been the development and the recent approval of a new class of drug called the DPP1 or cathepsin C inhibitors. They work in the bone marrow, so they have a very different mechanism of action to those previous generation of anti-inflammatory therapies. And they're not predicted to increase the risk of infection. And I'll explain why. There's a human knockout of DPP1 that's called Papillon-Lefèvre syndrome. It's exceptionally rare, 1 in a million people. It's an autosomal recessive condition with absence of activity of DPP1. Neutrophils don't release active proteases, and they don't make neutrophil extracellular traps, but it's not associated with a marked increased risk of infection, unlike most other neutrophil defects. And some data on the right-hand side there is from people with Papillon-Lefèvre and controls showing that their neutrophils are able to kill bacteria normally. But they don't make these harmful neutrophil extracellular traps that have been well described as being implicated in both bronchiectasis and CF. The major side effects that are predicted with these drugs based on the genetic evidence is hyperkeratosis, which is thickening of the skin, particularly of the hands and feet, and periodontitis in children. That's the major feature that's seen with Papillon-Lefèvre, which is not believed to be an immunosuppressive issue, and the skin is also not caused by infection. It's believed to be a failure of protease-mediated release of epidermal tissue. So predicted, this type of approach, if you target this mechanism, DPP1, you could reduce the levels of proteases that are well established as a treatable trait in both bronchiectasis and CF without increasing the risk of infection. And we've tested this now in a series of clinical trials in bronchiectasis, and I'll take you through those relatively quickly. The first trial in people with bronchiectasis was the WILLOW study. This is testing brensocatib, which was the first in class of this, at 25 milligrams and 10 milligrams versus placebo for 6 months. Patients were enrolled from a broad group of bronchiectasis patients, so CF is excluded, but PCD is included. Any other cause other than NTM and ABPA essentially were included in these trials. And the primary outcome was the time to first exacerbation, and you can see the secondary outcomes listed there. And this was a positive study. It was published in 2020. The risk of exacerbation was reduced by approximately 40% at both doses over a 6-month period. And you can see on the right-hand side of this slide, there's a powerful anti-inflammatory effect, whereas a lot of the previous generation of anti-inflammatories might reduce sputum neutrophils by 30 or 40%. Those are log scales on the graphs. You're looking at greater than 90% reductions at the 25 milligram dose in the levels of neutrophil elastase. You will also note the slow onset of action of these drugs. They work in the bone marrow where neutrophils are developing, so neutrophils then have to mature, they have to be released into the circulation, and the neutrophils that are already in the lungs of people with bronchiectasis have to be cleared and replaced by those new neutrophils. So you start to see a pharmacological effect at about 2 weeks, and you see the full effect at about 4 weeks. And you'll see that if you look carefully at the Kaplan-Meier curves that I'm going to show you in the next slides, that the separation is late. And that's an important limitation of these drugs, that they're certainly not something that you would be able to give to a patient and say you're going to feel better tomorrow. In terms of the exacerbation effect, it may actually take months before you see a really clear, robust effect. The success of the WILLOW study has led on to a number of other compounds being developed, and in fact, this is an incredibly busy development space. The next that I'm going to show you here is called verducatib, also known as BI 1291583. This was also tested in a phase 2 study. This is the same class of drug, but it's a more potent compound. It's dosed at 1, 2.5, and 5 milligrams in this dose-finding study. It concentrates more in the bone marrow, which is predicted to have a greater effect on NSPs and less peripheral distribution, which may be the underlying mechanism of things like the skin side effects. So that's the rationale for this compound. So 322 patients were enrolled. You can see the distribution in the bottom left of the patients enrolled, 2 to 1 to 1 to 2. And there was approximately a 30% reduction in exacerbations at the 2.5 and the 5 milligram doses. The dose response was statistically significant. The primary endpoint was met. You see on the Kaplan-Meier curve on the bottom right what I was talking about with the late separation of those curves, where the benefit is really in the second half of the trial. And that is a consistent feature with these compounds. So a 40% effect in the WILLOW study, approximately a 30% effect at the 2 doses here. The 2.5 milligram dose is going forward into phase 3. I'll come back to the phase 3 later. And then the third compound is now called flurenzacatib, but at this stage had an HSK designation, was tested in a 6-month phase 2 study in China. And this also showed a marked effect on exacerbations. In this case, up to 60% reduction in exacerbations at the highest dose, which is 40 milligrams. Again, you can see the Kaplan-Meier curves with this very characteristic parallel curves for the first few months, and then a marked divergence once that neutrophil effect kicks in. So that is very consistent across phase 2, that you have a clear reduction in exacerbations between 30 and 60% depending on the population studied. And this all led on to the phase 3 the phase 3 ASPEN study. ASPEN was the phase 3 of brensocatib. It's the first unequivocally positive phase 3 in people with bronchiectasis. It enrolled over 1,700 patients globally. Because of the lack of differentiation between the 25 milligram and the 10 milligram in phase 2, both doses were taken forward into phase 3. And what was seen was a 20% reduction in exacerbations over 1 year. And you can see no difference between the 10 and the 25. In the secondary endpoints, the major differentiator was an effect on lung function that was statistically significant for people on the 25 milligram dose with no effect in the 10 milligram dose. The overall between group difference is 38 mils. It's certainly not acting as a bronchodilator or improving lung function. It appears to be arresting the decline in lung function. There was no clear effect on symptoms in the sense that in the hierarchical testing, the p-values were not considered to be statistically significant. The safety profile was acceptable, although there is an increased risk of hyperkeratosis at the highest dose, particularly at the higher dose. So there are 4 cases of hyperkeratosis in the placebo group, 8 in the 10 milligram group, and 17 in the 25 milligram group. So there is a dose-related risk of adverse events. So we have now a licensed therapy for bronchiectasis. In August, this was licensed by the FDA in the United States. It's now being used for people with bronchiectasis in the United States, and it's going through the regulatory process in Europe. So that's a significant milestone for non-CF bronchiectasis. There are reasons to believe that this compound may be having other effects apart from simply acting as an anti-inflammatory and blocking the effects on pulmonary exacerbations. It's known from decades of work in CF and also some in non-CF bronchiectasis that neutrophil elastase drives mucus hypersecretion, degrades antimicrobial peptides, and therefore interacts with other components of the vicious cycle. And we've shown that in vitro in samples, in vivo in samples taken from patients in these clinical trials. This is from the Willow study published earlier this year in the Blue Journal. We see significant reductions in MUC5AC, the major pro-inflammatory mucin, particularly at the 25 milligram dose, and speculate this may explain why the 25 milligram dose has a greater effect on lung function. And you see the nice effect on SLPI as well. No microbiology was done in either the Willow phase 2 or the phase 3, but it will be interesting in future studies to see if we're also seeing changes in microbes as a downstream effect of brensocatib or other DPP-1 inhibitor administration. We've come a long way in the last 5 to 10 years from a place where really bronchiectasis had very few trials, or we had a few inhaled antibiotic trials, to this now being a very busy clinical trial space. This is from an article that we published recently in the Lancet Respiratory Medicine, mapping all of the different mechanisms that are either currently in trials or have recently been in trials in non-CF bronchiectasis. And it's a big list, and even this figure is now out of date because there's several more that have come out. So just, I don't have a pointer, but to go through this, at the top right, PDE3, PDE4, ensifentrine is in a phase 2 study in bronchiectasis patients. Anti-IL-5 is in a phase 3 study in bronchiectasis that we'll report very soon, the Mahali study. IL-33 is in a phase 2 run by Sanofi that will complete within the next year, I believe. There's a variety of early phase anti-inflammatory mechanisms targeting things like the inflammasome, IL-1, PDE4, alpha-1, and then there are novel antimicrobials that are coming through. And subsequent to this slide being made, there's recently been an inhaled immunoglobulin trial, which is a very large trial, more than 400 patients launching across the world. So we've gone very rapidly, building on the success of the DPP-1s, to become an area that's really full of trials. I'm going to show you one other set of trial data because I think it's particularly relevant to people with CF. And this is now switching gears into anti-infectives. So the other trial that will shortly kick off is a trial of a monoclonal antibody, an antivirulence monoclonal antibody approach against Pseudomonas. Inhaled antibiotics have not given consistent results in people with bronchiectasis, and the reason for that is unclear. But Pseudomonas is clearly a major problem. This is a study that we've recently published. This is a monoclonal antibody targeting two virulence factors, PSL and PCRV, in people with bronchiectasis. PCRV is the injector of Pseudomonas that allows it to compete with other bacteria and also kill epithelial cells. PSL is a virulence factor involved in biofilm formation and a number of other key functions of the Pseudomonas. We did a pre-study before we went on to this, doing whole genome sequencing in people with Pseudomonas, and showed in a global population that all of the patient's isolates had at least one of these genes. You only need one of them for the monoclonal antibody to work. We showed that using the antibody and adding it in vitro, you could block cytotoxicity against epithelial cells, and it also rescued a mouse model of Pseudomonas pneumonia. And that in neutrophils from people with bronchiectasis, you could enhance phagocytosis and killing of Pseudomonas by using this antibody that's called gromubimab. So in vitro, this looks like a promising approach for targeting Pseudomonas. And so this led on to a proof of concept study, a randomized clinical trial called the GREAT 2 trial. It's a small study because it's a proof of concept. What we did was we took patients with bronchiectasis and confirmed Pseudomonas infection and randomized them to 3 arms, 2 doses of the antibody gromubimab, which is given as an injection every 4 weeks, or placebo. And it was a 3-month trial with a 3-month off treatment period. I mentioned it was a small study, 37 patients randomized, 12, 13, and 12, and all of the patients completed the treatment period. They're a classical bronchiectasis population. PCD patients were included, CF was not included. The average age is 60, and the majority of patients are female, as you expect. That's what we see in most of our randomized trials. Because it was an exploratory study, it's small numbers, the p-value threshold for a positive study on the primary outcome of bacterial load was set at 0.1 pre-specified, so not the classical 0.05. And that was met by one of the doses. So gromubimab 500 milligrams dropped bacterial load by 1.2 logs, statistically significant. The higher dose was a bit noisier, but was also trending in the right direction. But what got us excited in this trial is we saw clinical benefits that we've not seen with antibiotics. Remember, this is antivirulence. Its primary mechanism is not killing the bug, but disabling its ability to cause harm to the host. And what we saw was an average 10 and 12-point improvement in the St. George's Respiratory Questionnaire. If you're not familiar with that questionnaire, 4 points is the minimum clinically important difference. There's nothing else we've ever trialed in bronchiectasis that gets close to that level of benefit. And we weren't really expecting to see anything on exacerbations because it's a 3-month study. And to our astonishment, really, there was a marked effect on exacerbations. So those are the Kaplan-Meier curves. The line at the top is the placebo group. The red is the lower dose group. The bottom line is the placebo group. The green is the higher dose group, and the red is the lower dose group. And the effect is remarkable. It's an 80% reduction in exacerbations at the high dose and a 69% reduction in exacerbations at the lower dose. All of this has to be treated with caution because of the small sample size, but it is a surprise given we've not seen this before with antimicrobials in bronchiectasis. Looking at the biology of this approach, we see a marked anti-inflammatory effect, particularly at the higher doses, with marked reductions in neutrophil markers, including on the right-hand side of this slide, neutrophil elastase, which clearly we've linked with exacerbation risk. So that may underlie what we're seeing here, which is it's not predominantly functioning as a classical antimicrobial, but it's reducing some of that bacterial-induced inflammation. And consistent with that, we also see a marked statistically significant effect on mucins, so a reduction in sputum mucins throughout the course of the study. So this is leading on now to a much larger study globally of this monoclonal antibody in people with bronchiectasis. And you can tell because I'm discussing it with this audience, I also wonder, given the ongoing prevalence of Pseudomonas, whether these types of approaches may also be of benefit to subsets of people with cystic fibrosis. So there's a lot going on in bronchiectasis, and a lot of the targets of therapies in bronchiectasis are highly relevant to people with cystic fibrosis. And so this The idea of putting patients together in a single trial is not a new idea, but it may be an idea whose time has come. And so the first trial that is going to enroll people with both bronchiectasis and CF in a single trial has recently kicked off. It's called the AIRtivity study. It's testing the DPP-1 inhibitor verducatinib. So AIRtivity is a phase 3 trial of a DPP-1 inhibitor, verducatinib, at 2.5 milligrams versus placebo. It's a 2-to-1 randomization, and it's enrolling anybody with any cause of bronchiectasis, which includes cystic fibrosis. The inclusion criteria requires 2 exacerbations in the previous year, or 1 exacerbation plus ongoing symptoms. That was the inclusion criteria that was also used in the phase 2. It's a relatively long trial. It's a year and a half. And you can understand why it's a year and a half now that I've shown you and emphasized that issue around the Kaplan-Meier curves, that these seem to be treatments that give a long-term benefit but need time to start working. So this will be an important proof of concept in terms of bringing these 2 patient populations together and in terms of thinking about co-development between bronchiectasis and cystic fibrosis. But there are a number of issues that have been encountered as we've started to discuss this trial, to develop this trial with people from the CF community, and to interact with regulators. We have been 2 completely different communities doing completely different trials with different endpoints. So we have different patient-reported outcomes. We have different definitions of exacerbation between the 2 populations. Our biomarker endpoints, our methods of collecting samples, everything has evolved slightly differently. Many of them, I'm sure, have huge overlap. I think our patient-reported outcomes are very, very similar, but they're not identical. And so regulators naturally have questions. Can you take a definition from one and apply it to the other? Do you need to collect the data differently in the different populations? And does that defeat the purpose of saying it's one population for the purposes of a trial? And then you have the question, what does success look like? Because you very rarely will design a trial where a subgroup, and in this case CF is a subgroup, will be adequately powered for p less than 0.05. So the question is, what will be an acceptable outcome? Is it if there's a 30 or 40% benefit in the overall population and it's the same in CF? Is it better in CF? What if it's slightly less in CF? Will that still be acceptable? All of these questions are important as we start to think about co-development. At the ERS conference last week, we had a workshop brought together by the CFF to talk about these issues between the different communities. And one of the things arising from that is the idea of doing a global study to investigate some of these questions. How do the questionnaires perform between the 2 populations? Is the biology sufficiently similar in order to bridge? So this is the outline of the one bronchiectasis cohort study. One bronchiectasis is the idea that this is all one population with multiple causes, CF and non-CF. And the design of this study is to enroll people with CF and people without CF, globally approximately 600 patients, and get the CF patients to complete some of the non-CF pros and the non-CF definitions of exacerbation, and vice versa, and see how comparable these populations are, where the gaps are in terms of what works and what doesn't work between the populations, and to try and generate the kind of evidence that will be needed to persuade the communities, regulators, and other stakeholders that this concept makes sense. So these are some of the questions that need to be answered. Comparisons between the patient-reported outcomes. We've got a work stream on CT imaging because that's becoming a very important outcome when we start to think about disease modification in bronchiectasis, and so those images will also be being captured in CF in some of these joint trials. And then the definition of exacerbation is particularly key. People who are developing drugs want to know that there's an ongoing burden in CF, that the microbiology, the inflammation, the other treatable traits are comparable between these populations, so doing some biological characterization is also going to be very important. So I'm really excited that there is an initiative now to pull everybody together and to potentially see if we can develop drugs that can benefit both populations. So I think where we are now in terms of bringing things into the world of CF, there is more that unites us than divides us. There is more between bronchiectasis and CF that is common than is different. and the things that are different, in my opinion, can be bridged. We have new anti-inflammatory treatments for people with bronchiectasis, and there's every reason to believe that some people with ongoing burden of disease with CF could also benefit from those therapies. There are challenges in CF clinical development, and people in this room know this better than me, that the improved health status for many patients will make it more difficult to measure benefits in people who, for example, have normal lung function or a lower frequency of exacerbations, requires larger trials, different trial designs, and that presents a challenge but also an opportunity. And these anti-inflammatory therapies, particularly the AIRtivity study, will be the first in what I expect to be a new generation of trials that bring the community together. And so we, as predominantly academics in this room, need to think about how we facilitate that and how we make sure that the data that we generate gives us the answers that we need so that both patient populations benefit. So thank you very much again for asking me to come and speak to you. I will finish with one plug. We are bringing these populations together. I want more and more CF researchers to think, how can you apply your skills to non-CF bronchiectasis, because you have an extraordinary amount of experience and knowledge. I run a network called EMBARC, which tries to facilitate research in non-CF bronchiectasis, and we have vast amounts of data in our registry, and also an open biobank which is available to any researchers with valid questions. The biobank is called EMBARC Bridge. The website is there. If you've got people that would like to do research in bronchiectasis, we have an enormous amount of data and clinical material that patients have donated specifically for translational research and clinical research. So I take the opportunity to encourage this community to think maybe we could compare our CF populations to bronchiectasis and answer some of these questions. So with that, thank you so much again for inviting me. Thanks to all of our collaborators that took part in those studies that I showed you.